and Dr. Rick Wolthusen. So I would like them to introduce themselves, please.
Well, my name is Leslie Bronner, and actually I was one of the educators last year. I worked on the post-traumatic stress disorder lecture, but glad to be back. I'm currently an inpatient psychiatrist here at Duke University.
I am a PGY2 at Duke University. I was also an educator last year for the psychosis lecture and the empowerment and advocacy lecture. As you can hear, I'm not from the US, I'm from Germany. And apart from my clinical work, I work with governments in Ghana and Kenya and Germany on mental health policies. And my second background, apart from psychiatry and medicine, is in public policy. That's why I'm super excited for this lecture tonight.
Sorry, I keep muting myself. Okay, so I'm gonna have Dr. Bronner share her screen.
Okay, let me, hold on.
So the first thing I wanted to know is, where is everyone located? So if you have your phone, please go to www.mentee.com and use this code here and just input where you're from. We have people from all over the place. Yeah. Charlotte, Detroit, Baltimore, Maryland, Fort Worth, Miami, Portland, Oregon, Northern Virginia. Wow. Does it scroll on itself? Yeah, by itself. DC. Dr. Bronner, could you scroll down?
Let's see. Oh, here we go. Okay.
Oh, Wisconsin, Connecticut. Wow. Orlando, Bowie, Georgia, Maryland, Durham, Flint, Michigan, Falls Church. Wow, we have people from all over the place. So as you can see, there are people from all over the US in this lecture series. So there's going to be a lot to learn from each other as well as from this course. So please be open-minded. All right, so I will continue. I'll actually let Dr. Bronner go and introduce our learning objectives.
Okay, so our learning objectives for the evening are: understand why social determinants of health are relevant to health outcomes, understand how structural racism creates and perpetuates health disparities, and critically consider what role advocacy will play in health outcomes. And I just wanted to show the CDC Health Impact Pyramid, which we will talk more about as the lecture goes on, and probably you will see this many, many more times. But in general, the pyramid suggests that if you want to have a large impact on population health, you will focus on the social, economic factors here at the base of the pyramid. However, in this country, we spend most of our money up here in clinical interventions, waiting for people to get sick. And so just some things to ponder, why do we focus on the upper part when we notice that the largest impact is here at the base? And if we're focused there, how can we focus on the right solutions? And then where would you fit in as advocates? And so that's something for y'all to think about, and we'll talk more about as the lecture goes forward.
Right. All right. So I hope you guys all got a chance to play the Spank game. We are going to break you guys out into breakout groups and have you guys talk about your experience. I know that the first time I played it, it was a very stressful experience, even though I grew up low income. It just reiterated the fact that where you start does dictate where you end to some extent, especially when it comes to mental health. So I'm really looking forward to what conversations you guys have and how this game impacted you. So we're gonna go ahead and break you guys out into breakout groups. These questions are going to be sent in the group chat so that you guys have it with you guys as you guys are in your breakout rooms. Sorry. And you should be in the breakout room shortly. We're going to give you guys around 10 to 13 minutes in your breakout rooms. So you'll get like a 1-minute warning when we're pulling you back. And I'm going to start a timer once everyone is in their breakout rooms. Okay, so it looks like most people are back. All right, so it's okay if you didn't have a leader to your group. No worries. I hope it was like, these questions are just to guide you just in case it was like crickets inside, but this game is honestly causes such a visceral reaction that I feel like you guys had good conversations. So could anyone tell me what, like, did anyone win the game? Oh, Christina, you won the game.
I was trying to unmute myself. Yeah, so I won the game the first time I played, but I don't think I necessarily put myself in the shoes as well as I could have. So then I played it a second time where I actually was like, okay, would I actually give my dog away if I didn't have money? And the landlord found out that I had a dog, and I have a dog, like it's my first dog I've ever had, and he's sitting over there on the couch. But when I actually thought about it, I'm like, no, I would not give my dog away. I'd do everything in my power to not do that and like not have to give him to the shelter. I would pay the fee. And then I didn't win because that was like $350, I think. And that's a lot of money. So yeah, it was tough. And the decisions I had to make to win the first time were very tough. And then when I didn't want to make those decisions, I didn't end up winning.
How about you, Mohammed?
Yeah, I think in a similar vein. The first time I played it, I was like just trying to see if I could get to the ending of the game, which I managed to do. Then played it again with some friends, trying to do it in a more like what I would actually do in this situation to like how I would actually make these decisions. I didn't last over a week or a week or two, so it was very like there is a way to get to the ending, but it was more just like I think in reality it would have been a very difficult situation to get to it.
Yeah. How about you, Rashana?
Yeah, so I guess you can say I cheated in a way, but not really, because the first time I played, I didn't make it past, I think, 5 days, but I didn't like my job. So I was like, we're going to try this again. And that time I actually made, I think, the whole 30 days, but I lost my job at the end of it and I had to like survive of what was left.
Was there anything, what surprised you guys most while playing the game? Feel free to put your hand up or unmute. Yeah, Melissa, go ahead.
I think what surprised me the most was how many decisions you had to make between staying financially afloat and like your well-being or your family's well-being. And it was stressful just having to run like the simulation or play the game. I couldn't imagine like being the head of a household and making those decisions.
How about you, Christina?
I was gonna say it's kind of crazy when you put it in perspective, like how many things that were unexpected that kept coming up, and like how many curveballs like life would throw at you, and how like you'd have to make very like hard decisions. Like for example, like not paying the registration on a car, taking the risk on that, but then getting your car taken away from not making payments on your car, and just like those things keep building up. And then if you can't have your car, you can't get to work, and then you get fired from your job, and then you can't pay rent, and it's just like a big domino effect, basically, and it made it very hard to live.
Okay. I think we'll do one more person and then we'll continue on to the next one because I think we're running a little out of time. Ngozi.
Hello, and I think just to piggyback off what Christina said, just seeing how like if you didn't pay, if you have a choice either to pay it in the front end or in the back end. So for instance, like if you had an issue with like your dental health with your tooth, if you could choose to you could choose a short-term effect just to save costs for that short period of time. But at the end of the day, it would be a long-term effect that you would have to run into in regards to paying more money just now to remove the tooth. So you couldn't really avoid cost.
No, it's the most expensive thing is being poor. Most expensive thing. Especially when you realize, like, in some neighborhoods, people have to rent their furniture, and renting your furniture is so much more expensive than keeping long term. So yeah, I will have one more question, just because I really want to. I'm just interested. Had playing spent, has it shifted your mindsets at all? Sounds like that's no. All right. All right. Let's. Oh.
For me, it didn't really shift my mindset, but more likely just like, in a way, brought awareness to people who are also going through like similar problems. In a way, it was also like relatable. So it's like you're not the only person who's also going through this.
Mohammed?
I think there was certainly a shift in mind. I think it was like just the level of like continual stress. So I always thought there to be stressors and uncertain time points, but this was like a continual 30-day stress. And then there's the kicker at the ending where it's like, if you get to the ending, it's like rent is due tomorrow. So like, and then so then you realize it's a continual cycle. It's just going on and on. I think that was like one mindset. I was like, this just doesn't stop at any point.
Thank you guys all for speaking. No, Arslan?
Yes, I think for me, it really made me question, change my mindset in a way that, some of the decisions that you had to make were moral decisions, that I would have chosen, one way morally versus, another way if I were just trying to survive. And so, sometimes, it's hard until you put yourself in that person's shoes to realize, that even, what appears to just be a purely moral decision on the surface has so much, going on behind it, so many factors that influence people. And so, being able to be mindful of that, I think is something that playing the game sort of helped me with.
Thank you, everyone who shared. Okay, I think we can go on to the lecture now.
Okay. Okay, I'm going to be talking about social determinants of health, and subtitle, Are We Focused on the Right Solution? So the World Health Organization definition of health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Social determinants of health are the conditions that are in the environment in which you live that affect your health, your functioning, quality of life, and risk of disease. And so what we normally say is really your zip code, the environment that you grow up in, and not your genetic code, i.e. your biology, that determines health. So there are 5 domains of the social determinants of health: economic stability, which would include things like employment, food insecurity, housing stability; education, that might include early childhood education, enrollment in higher education, and high school graduation; social and community context might include incarceration, discrimination, and marginalized groups; and social support or social cohesion. Neighborhood and built environments can include things like crime and violence, and environmental conditions like clean air and clean water. Then you have health and healthcare, and that can include things like access to primary care, education, and screening. So as I mentioned earlier, when we talked about the pyramid, that most of the impact in health comes from social determinants, but we as a country, we have spent in 2020 $4.1 trillion on healthcare. And this slide just shows that those numbers are only going up, and you can see how that compares to Social Security, how much we spend on Social Security, and how much we spend on defense. And this slide just reiterates the fact that most of what we consider to improve our health is not healthcare, which is this bottom 20% that would include medical care, but it's the socioeconomic factors, physical environment, those two together, which would be the sort of zip code, and then healthy behaviors. But if we look at how we spend the money, and this is just in 2019, and we spent, close to 4 trillion or $3.7 billion. This yellow sliver is less than 5% of what we spend on healthcare, and that's in public health. And that would be related to all the social factors. And so it's no wonder that we're not doing well in this country. And so just to have a comparison to other countries, the US, we spend, this is per capita, so it controls for the population size, but we spend twice as much per capita as other countries. And if we look at measures of health, such as infant mortality, and it may be hard to see this slide, but as you go down, the infant mortality goes up, and the United States is way at the bottom. And if we look at something like life expectancy, again, life expectancy based on this slide, it increases as you go up, and you can see the United States towards the bottom. And so all the money that we spend, we're not really seeing that in positive health outcomes. And so if you look at life expectancy just in this country, you can see it depends on where you live as to what your life expectancy would be. And if we just drill down and just look at Detroit, you can see that based on your zip code, the life expectancy can change. And so we've talked about the social determinants of health, how important they are, socioeconomic factors that impact health. And we're looking at the zip code versus your genetic code. But one of the things that we haven't talked about is what is the greatest impact on the distribution of resources? What is the greatest impact on the opportunities that one may have? And one major factor is race. And so racism being prejudice and discrimination directed against a person or people that based on just their membership in a particular racial or ethnic group. But what we really want to focus on is institutional racism or structural or systemic racism, which is a form of racism or bias that is embedded in laws, regulations of a society, and an organization that ultimately dictates the opportunities that one has and the distribution of those resources. And so one prime example of this is looking back at the history of Black people in this country. And so slavery, as we all know, is the legal treatment of Black people as property. And so Black people had to endure a lot of violence, and they lived in very, very poor conditions. And this was actually the sort of start of Black people not having the opportunities and the resources that they needed to improve health. Then you might say, well, slavery was a long time ago. The Civil War ended, the 13th Amendment abolished slavery, but shortly thereafter, we had Jim Crow laws, and those were put in place it was said to be separate but equal, but it was put in place to maintain Black people as second-class citizens. And they, again, continued to not have the opportunities and not have the opportunities and resources in order to improve their health and their living conditions. And so during this time, around the 1930s, there was a practice called redlining. And this was a discriminatory practice which services were withheld from potential customers in certain neighborhoods that were considered hazardous or so-called high risk. And of course, those neighborhoods were occupied by Black and minority populations. And well-known examples of redlining were denying people credit, denying insurance, denying them health care. And of course, if you don't have credit, then maybe you're not able to buy a house, maybe you're not able to get a car, maybe you're not able to live in a neighborhood, the neighborhoods that you want to live in. And so again, there were these systems that were put in place that denied Black people and minorities opportunities and denied the resources that would allow them to be healthy. And redlining was supposedly still in effect even after the civil rights movement. And that was probably towards the 1970s. But then we also have the war on drugs, in which I probably could also put the crime bill. And this was starting in the 1970s, 80s, and 90s with Nixon, Reagan, and Clinton. And during this time period, Black men and minorities were disproportionately incarcerated to the numbers of hundreds of thousands. And so one of the issues was in the 1980s when crack cocaine was on the rise. 1 ounce of crack cocaine would cause you to be be a part of the criminal justice system, but it took 100 ounces of powder cocaine and powder cocaine. Crack cocaine was used more among the Black population and minorities, and powder cocaine was used more among whites. And so the crime bill also said that there was mandatory minimums, there was truth in sentencing, 3 strikes and you're out. So once you actually got in jail or prison, it was very hard for you to get out. And as we all know, even when you are actually able to get out of prison, you don't have anything. You know, you're actually considered a second-class citizen as well, and you're not able to get good jobs, good housing, insurance, etc. So there are many instances since slavery that laws have been put in place to limit the opportunities that Black people have had. And it's not to say that this and those issues were not individual issues, but obviously these are the things that people had to deal with in order to move forward. And so where does that leave us? Oh, and actually I just wanted to show this slide that shows redlining. And so if you look at the red and yellow areas, that shows the areas of redlining. And then if you look at the dark purple, the darkest purple areas, that shows the areas of social vulnerability. And so this gets us into and shows us that we still have disparities in social factors like unemployment rates, income and wealth, home ownership, and this is about childhood poverty. And this is about life expectancy. And you can see that the bottom line is Black males have the lowest life expectancy, and Black people in general are next. And then you can see at the top, you have white females, and below that are white people in general. And so as we know, the social determinants impact health. And so therefore, we're going to have disparities in health outcomes. So you can see high blood pressure. You can see diabetes. African Americans are in the red and whites in the blue. In stroke, in all-cause mortality. And as we all know, in terms of the pandemic, and because Black people have been dealing with all of these underlying issues for so long. When the pandemic came through, of course, they were going to be at risk for bad outcomes. And you can see that in this slide. And this slide just shows that racism and discrimination and violence that is associated with that can lead to mental health outcomes in and of itself, but also that can compound the other social factors that we have looked at and can make all of those things a lot worse. And so these are things that you have to be thinking about when you're looking at social factors, that racism and discrimination are very, very important. And so this slide just shows, and you probably have seen this in various forms, but on the left top, you have inequality, and that's just unequal access to opportunities. Then you move on to say that we want to be equal, so you give everybody the same thing. But as you can see that we haven't actually solved the problem. Equity down at the bottom left shows that we're giving people what they need. So if they were in deficit, then we're giving them those things. But actually, in order to fully solve the problem, you have to look at the system and change the system. And so that takes us back to the health impact pyramid. And so, you know, we can see that social factors are very important in terms of making people healthy. But we have to go back to the questions of, if we know that to be true, why are we spending all of our money at the top of the pyramid? And one of the things that comes to mind is that one of the big issues in the unequal distribution of resources is racism. And that is a big thing to tackle, as we all know. And so that might be one of the reasons why we're focusing in places that might be easier for us to deal with. But that is just one of the things that I'm thinking about. But I'm sure this is a very complex issue. And, you know, I wonder what other people are thinking about that as well.
I think Kalani had, sorry, Kalin, did I say that right? You want to tell your question?
Oh, okay, thank you, Callan. So yeah, my question was in terms of the life expectancy. I'm just looking at the number. It looks like a small number, but I know that's only because of, you know, my ignorance of this issue. So I'm trying to wrap my mind around like the relevance of 1 year life increase in life expectancy. What does that really mean?
Are you saying that in terms of the differences between males and females, or
No.
races?
So you were showing the difference in life expectancy across zip codes, and so I was curious. So I saw like red was 70, but then yellow was 73. So from my eyes, like being a hard scientist, 3 years doesn't mean a lot, but I know to you it means something else. I'm trying to wrap my mind around what those 3 years really means.
Well, I mean, I think, you know, 3 years may mean different things to different people. I think it's just mainly showing that your environment impacts those things, and that just living down the street or across the city from somebody can impact how long you live. Now, whether one believes 3 years or 1 year or 5 years is important, I think is a different question.
I was also going to say that statistically, you know, there's a difference between them taking like a couple people from each zip codes, but you take, you know, thousands of people from each zip code and compare it, those 3 years are going to be statistically significant. And so that is sort of where, you know, the significance comes. And I know just in DC, like the life expectancy from Northwest to Southeast DC, which is more Black and poorer parts of, is like 9 years, just like it's like 6 miles apart. So depending where you are, those differences are even more drastic.
Yeah, they can be even much bigger. Yeah.
Right. Yeah, I think that's what I was thinking of in terms of the statistics, like what events. So I guess I'm thinking difference between 70 and 73. 70 could be more gang violence, so you have more people dying at 20, although you have people living until like 80, whereas in like maybe 73 you have people dying for different reasons, mostly at 50, and then you still have some people alive at 80. So things like that is what I was thinking. So I guess it also just depends on the distribution of ages in that population, stuff like that. So just trying to get a feel of what other events could change the life expectancy. But I get it. Thanks.
Ms. Cassie?
Yes, I kind of just wanted to add on to what we were just talking about and say it's also kind of crazy to think that by simply say move your family across the street, you just add a year. Like it doesn't seem that significant in a sense of it's just 1 year, but when you think of I can do everything else to my own capacity, right? But all I would actually have to do to just get like 1 or 3 more years is just move to a place with probably say better air quality, better resources and things like that. So I think that's where the 1 year becomes more significant.
Yeah.
I think the other component, we look at life expectancy, but also like what's the quality of life in addition to life expectancy, right? Because even like nowadays, neighborhoods just look different in terms of like their road conditions, in terms of like the house infrastructures, like are they isolated, in terms of like how old are the houses, in terms of like how many trees and parks are close by. They can provide shadow and shade, so the house is not overheating, like all these things. So I think it's not only about life expectancy, but then also about external factors, which, ultimately, I guess, contributes to quality of life as one part. I mean, there are many parts contributing to quality of life, but I think overall, life expectancy is an important indicator, and obviously there are more.
Okay, so we are gonna take a 5-minute break. If anyone has any questions between then, feel free to ask them, but I'm setting the timer for 5 minutes. And let me see. All right, it's starting now. So we'll see you back in 5 minutes. I'll share the timer so everyone sees it.
Okay, let me stop sharing.
All right. Here we go. Do you see my screen?
Yeah, we see it.
Perfect. So welcome back, everyone. I think this part is going to be a little bit more interactive because we also want you to think about some of the issues Dr. Bronner just highlighted beautifully. And, if I just want to stress again, if we walk backwards, what we see in the clinical setting, we have a lot of like health disparities we see. And, health disparities have different reasons. So there are different reasons why there are health disparities, but it eventually boils down to existing structures, like structures human beings at some point thought they should be in place and, which don't change fast. As Dr. Bronner was saying, racism is real and it doesn't change fast. So we're looking for technical fixes, right? We are looking at the top of the pyramid, but really what we need to look at is the bottom of the pyramid. We need to look at policies. We need to look at like economic systems, social hierarchies, and all these kind of things. And really, we need to look at the structures. And what we try to give you, is some knowledge about structural competency, or like what are the structural determinants of the social determinants of health. Like what is actually in place to keep them up and going. I also want to highlight that when we talk about these things, we certainly talk about people of color. We talk about Latinx people. We pretty much talk about LGBTQ people as well. literally all the populations which identify or like are, I guess, are part of the umbrella term DEIJ, right? And so while we present certain examples tonight, we also want to be clear that we're not exclusively talking about one group. The other thing I wanted to do is like to just give you an example. You know, this might be a patient we might see in the emergency department, and you might get consulted by the medicine team and saying, well, there's a guy who was intoxicated. He was brought to the emergency department after he was found on the street and he seems intoxicated, right? So what do you think is going on? And so what we do is like, you know, we assess the patient and we say, you know, he or she or they're surely intoxicated. You know, we can get a urine drug screen. We can look into someone's blood to see what medications or substances they might have used. They have like particular symptoms. And what we then recommend is like, you know, let the person, give the person some time so that the intoxication goes away, the symptoms go away, the person is exhibiting, and, you know, then we can reassess the person, usually in the morning, because oftentimes they come overnight. But, you know, reassess the person and see if it is safe for the person to discharge. And that's pretty much all we look at, right? I mean, that's our job, to determine if someone is safe to discharge home or not. Or, you know, do we need to say someone actually need to be hospitalized for safety concerns? And if they need to be hospitalized, then do they agree to be in the hospital? Or do we need what we call here in North Carolina an involuntary commitment, which is basically, do we take away someone's legal rights to enjoy their freedom of, you know, being outside of the hospital and doing what they want, because we think they need emergency psychiatric treatment. What we don't see is, you know, this man, there are different stories, or this woman or this individual might have a backstory which we're not really aware of, right? And so I just like have this full graph here. You know, these are all the events, like this is what we see, but this is a very small percentage of what we actually see, right? And like what the history we actually get. And you know, and this is like based on real examples of like people we see, but you know, someone from the southern part of, like, for example, Mexico, who's trying to sell corn, but really is struggling to sell any kind of corn because, you know, there's a lot of influx of cheap US corn into Mexico, which then means he cannot have employment. The person is hoping for a better living in the United States to come to the US, maybe legally, maybe illegally, like undocumented. They begin their work as a day laborer because, you know, they might be undocumented. When they injure themselves and they cannot work, they don't have insurance. They might lose their job. They cannot really pay for the rent. They have to move to the street where they get assaulted. And because of the assault and like the financial situation and living on the street, someone starts drinking heavily. And then what we see in the emergency department is actually the person who's intoxicated, but we don't know any of the backstory. Then when we try to fix someone in the emergency department, you know, by just waiting or assisting medically with, if someone, you know, is intoxicated, we can assist medically, but certainly we are not like tackling any of these conditions, right, which led to the person drinking alcohol or using a substance at the first place. And so I think, like, just to clarify what structural racism and structural competency means in this context is basically being aware of all the factors contributing to these separate conditions. And I was just like outlining a few thoughts here, right? I mean, why is the US importing cheap corn into Mexico? Well, because there's NAFTA, the North American Free Trade Agreement, which allows the US to do it, and you know, which kind of like economically creates incentives for the United States to import certain products and then to export corn to Mexico, which then makes it, you know, very hard for people in Mexico to actually sell their own corn. As I mentioned before, if someone is coming to the US, they might be undocumented. They might not have, you know, access to services people have when they are documented, or, you know, they might not have access to certain jobs because they're not here legally. They cannot access healthcare, as I mentioned before, because they might be undocumented, or they're just making a certain payment. Then what's really causing that he cannot pay his rent? I mean, obviously he's losing his job, but also he might not be able to pay the money because the neighborhood where he was staying in, the rent is just getting more and more, which is then related to the fact of like gentrification and displacement. Then he can move further away, and like he drives to work, but then the idea. I think you got the idea when you played the spend game, that you can certainly live further away and pay less of rent, but then for each dollar you save in rent, you're also spending a certain amount on gas, right? And so again, like these are the things we're not really fixing up in our system when we see people in our emergency department. For the next couple of minutes, I would like to bring your attention to Mr. Michael. Mr. Michael is a made-up case based on all the patients I've seen, but Mr. Michael's presentation is very common. And just to give you some general guidance, what we are going to do over the next like 30 minutes or so, is we're going to talk about Mr. Michael's case in like 3 chunks. We're starting here. We just read about Mr. Michael. We are brainstorming as a group about the questions I posed at the bottom of the slide. Then we get some more information about Mr. Michael, and you guys will go back into the breakout rooms and brainstorm some more. And then the case is going to end with some questions, which are going to lead us to some advocacy work stuff, thinking. And I want us to start thinking about this as a whole group, and the team will help us to compile a handout of resources based on what you guys all contribute. So we really look forward to hearing from you. That's the next, probably it's going to be the next 30 minutes or so. So let's actually start with Mr. Michael's case. If one of you could actually read the case, I would appreciate it. And then Bruni also sent you guys a link in the chat where you can access the case of Mr. Michael as we go. But please, if you open the document, please do me a favor and don't keep on reading, only read the first portion. Anyone who wants to read about Mr. Michael? If not, I will, but I think you want some break from my talking.
I can read.
Yes, please.
Okay. Mr. Michael is a 21-year-old Black male. He is single. He was always a B student in middle school, but started to get more C's than B's in high school. He started college, but took a job less than a year after enrolling in college. A few months later, he began to self-isolate, and his mood seemed lower than usual. He did not sleep well and lost 20 pounds over the last 3 months. He eventually lost his job due to his low energy level and his inability to focus recently. A few weeks ago, he started hearing voices about people wanting to harm him. He also felt that some people come after him. During the psychiatric intake interview, he seemed disorganized. It was hard to follow his train of thought. The team eventually diagnosed him with schizophrenia and started him on an antipsychotic medication called haloperidol. His condition only improved slowly. After a few days in the psychiatric ward, the team received a call from the patient's insurance company. The insurance company stated that it would stop paying for the patient's hospital stay the following day. The interdisciplinary team quickly put together a discharge plan and discharged the patient the next day.
Awesome, thank you. So that's the case we are confronted with, and now all of you are part of this interdisciplinary treatment team. And then the first question is I guess a little more clinical, but it also gives us some insight into some other disparities which we see in the mental health sector specifically. So I know that some of you might have had some exposure to psychiatry and mental health, and the patient was diagnosed with schizophrenia. For those of you who have some idea about schizophrenia and what the symptoms are, can you give us some insight? What the symptoms are? And you can make it, you don't have to recall it, you can just make it based on the case.
I know one of the symptoms is kind of like having an altered sense of reality. So I think one of the key things in probably diagnosing schizophrenia was the fact that he heard voices. That's one of the things.
Yeah, and we call it hallucinations. Like, people perceive something which without any external factor or stimulus. Yep. And then I think the other thing you said, I think you both said it at the same time. He also felt that some people come after him, which we call paranoia, which can also be a part of schizophrenia. Yeah. What else?
In the case, it says that he started to self-isolate, so he kind of like dissociated with other people and social situations and became more disorganized with his behavior.
Right. So disorganized thought process, right? Like people are all over the place. And then the self-isolation. Yeah, what else?
I'm wondering if he was worked up for anything non-psychiatric. It doesn't say that, but
that's right.
Immediately jumped to the conclusion based on the hearing voices.
That's right. And unfortunately, that's a common, more or less common condition we see in the emergency department, that, as soon as people seem to have some psychiatric condition, that we are called, but, we are always saying, well, we cannot make any determination unless we are sure that no medical condition or medication or substance is causing the patient's current state, right? So certainly, like, we need a medical workup to do especially because, as Dr. Bronner was showing, people, like certain people who suffer a lot from health disparities at the baseline have more medical conditions, which can certainly contribute to some of these presentations, right? What else?
I was just going to add that the timeline doesn't add up for schizophrenia, for his symptoms, for his disorganized thought and his hallucinations. Like, I think it's usually like 6 months to make a diagnosis of schizophrenia. So I agree that they should sort of think of different things to diagnose.
Yeah. What else?
Also, couldn't it be something like trauma related? Sometimes, like, I know symptoms for different things kind of overlap, so it may not necessarily be like a disorder as in schizophrenia, but more just like his response to something outside.
Mm-hmm. Absolutely. We don't know enough about his history, right? I mean, is there any sexual trauma, any physical trauma, any emotional trauma, any neglect? Was there any altercation with, like, institutions, like police officers? Oftentimes people who come have a lot of, like, altercation with the justice and the police system and the court system, and there are a lot of, like, negative emotions and trauma involved. Absolutely. Then the other thing I want to point out, right? I mean, so he gets, like, more B's than C's. He has a job, which he then kind of loses. His mood seems lower. He doesn't sleep well. He's losing appetite, low energy level, inability to focus. What does this remind you of?
Possibly like depression.
Yeah, depression, exactly. And, oftentimes people either they have both, right? I mean, they can have depression and schizophrenia, or they just have depression and, there's kind of like symptoms of psychosis of schizophrenia are just consistent with the depression, or they can have schizophrenia with a lot of negative symptoms, which mimic depression. But the story being that, it's too early to say what his condition is. But, and here's the learning point, we see there is, when we compare different populations, we see that people of color oftentimes have an unproportional higher diagnosis of schizophrenia compared to other counterparts, and that this is not justified. If we did some more questioning and some more diagnostic clarification and serial assessments, oftentimes the people who were diagnosed with schizophrenia at the first place would actually turn out to be, a medical case, or like it's substance use, or it's actually a mood disorder such as depression, right? And not only are certain populations diagnosed with certain psychiatric conditions more often, but also their treatment is really different, right? I mean, haloperidol, it's a good medication, but then the question is, what would have someone else who is not a 21-year-old black male have gotten instead? We know that people might not necessarily get evidence-based treatment. So these are the learning points. And I guess it's part of an appetizer, because you know there's going to be a workshop coming up about psychosis and schizophrenia and how it relates to health disparities, and you know it will come up again. Now, why do you think we already talked about question 2, and then number 3, the discharge process is complex. What kind of like elements go into this? Like, and if you don't know it, you know, maybe you had a friend or a relative staying in the hospital or yourself. So what did the team potentially think about when they discharged him?
Maybe his family situation, like who's taking care of him at the moment, if he has.
Yeah, what else?
Is he of danger to himself
Mm-hmm.
or others?
Yep.
Can he afford his medications?
Yeah, very important, right? We put someone on haloperidol, but then what happens after they leave the hospital? Are they able to not only afford it, but like who's prescribing it, right? What else?
So linkage to continual care.
Mm-hmm. Exactly. And then what's the issue of continued care? What do we oftentimes do? We ask a patient, where do you live? We open Google Maps and we say, well, that's a provider in your neighborhood. Go there. It might not necessarily be accessible for the patient, right? Maybe they don't have transport. Maybe there are other reasons why people cannot go to a certain place. But we have done our, diligence, and we can check the box and say, discharge. I mean, we got them a mental health care outpatient provider, and they will prescribe medications, and then they will pick up the medications and pay for it. But there's so many assumptions we are making in this whole process, right? That this is not necessarily what's happening. So let's actually continue with the case, unless you have some urgent questions. All right, I don't think that's the case. Then let's go to the next page. Can we have someone to read again, please?
I can read it. The patient was discharged to his aunt's place. Both patient's parents died from gun violence when the patient was 6 years old. Since then, the patient and his 5 siblings have stayed with his aunt. Upon discharge, the patient received 7 tablets of haloperidol and a prescription to pick up pills for 14 more days in a local pharmacy. The patient was also given a follow-up appointment with a mental health provider within 7 days of discharge. The patient is brought back to the psychiatric emergency department by police officers 11 weeks after discharge. The patient's aunt filed a petition with the magistrate and wants the patient to be examined to decide if he meets the criteria for involuntary commitment. When the team called the aunt, she stated that she no longer feels safe around the patient. He started going in and out of the house for no apparent reason. She cannot follow his thought process. He constantly says, "They will get me." He seemed to talk to himself. He started carrying around a knife to protect himself. The aunt stated that her neighbors stopped talking with her once they saw the patient carrying a knife outside and screaming. The aunt stated that the patient cannot return to her home at this point, especially if he does not take his medication, such as last time. She stated that he did not follow up with any mental health provider since discharge.
Perfect. Thank you. And so we already started discussing some of the questions, but I want you guys to go into your small groups and discuss some of these questions in more details. The questions being, what do you think prevented the patient from taking his medication? The second question being, why do you think the patient didn't go and follow up with a mental health care provider? And then the third question being, if you're in the process of becoming a mental health advocate, and if you decide to actually work with the communities, one of your jobs could include to find out more about why the neighbors stop talking to the aunt, what's going on, right? And potentially provide some education if needed. And so the question then is would you actually do anything about the patient's aunt's neighbors? And if not, which is also a reasonable option, why not? And if you decide you want to do something, what would you actually do? And for this part, we are gonna brainstorm in small groups. We're sending you into breakout rooms of 3 people per room. One participant is responsible for reporting out per question, meaning, if you're 3 people, one after the breakout room, we are going to hear from some of you. And then, someone will volunteer per breakout room to report back on question 1, and someone will volunteer to report back on question 2 and then question 3 as well. And then we are going to pick only like 1 or 2 breakout rooms for each question so that we stay within the time limit. We think you will probably need around like 9 to 12 minutes, but we will check in with you after 5 or 6 minutes to see where you guys are, so that we can see how much longer you guys need, okay? Any questions before we go into the breakout room? Are the instructions clear? This does not seem to be the case. And in this case, I asked the team to please start the breakout rooms. Thank you. All right, welcome back, everyone. I hope you had some good discussions in your groups. Again, I don't want to put anyone on the spot, but if someone feels compelled to share some of the thoughts they had about question number 1, it would be nice to hear from you. Question being, what do you think prevented the patient from taking his medication? Shelby.
We had a couple, like a handful of reasons. I'll just mention a couple to give other people some time to talk. But assuming his schizophrenia diagnosis is correct, he could be untrusting of people and institutions. He could also maybe dislike the way that he was treated when he was hospitalized. So he is distrusting of that. It could come down to like a financial situation. His insurance said that they weren't going to cover him anymore. So are they going to pay for this medication? Are they going to pay for that follow-up visit? And then transportation was a final one that we talked about. Can he get to his appointments when they were scheduled?
Yeah, great. I like the mistrust. Not only, I think it's very right to place it in the context of schizophrenia, but I think you also said something very important, which is like some people just mistrust the medical system at the first place, right? For all the bad experiences, the bad medical interactions they had with the medical system in the past. And we are not building the trust, rebuilding the trust in like a week or 2 of an admission, right? So it's something to be aware of, and like kind of assuming that they trust us when they come in at the first place is just a wrong assumption. So great, yeah, really good points. Miriam, I saw that you had your hand up. You might have taken it down by now.
Still up, but yeah. One of the things we discussed, I thought about some of the complications of schizophrenia, assuming it was the right diagnosis, is the suicidal thoughts, just because of like paranoia and all these intrusive thoughts. It could be something that the patient thinks that's the only way to rid themselves of that state of mind, is maybe feeling helpless and hopeless, and that could have been a reason why they stopped taking the medication. And also financial constraints, and like the person before me mentioned, and the health insurance being unable to pay for their stay at the hospital, and maybe financial complications.
Yeah, absolutely. Great. Tiara.
Hello. I was also piggybacking off of the topic of mistrust. We're also thinking that maybe he just doesn't feel that he needs his medication, at all. Also that he may not be comfortable with taking the medication.
Absolutely. 21-year-old, right? Who might be otherwise healthy, who has never taken any medications in his life. All of a sudden, we are asking him to take medications, and he might not even want to take medications daily, right? The other thing I think, which is very important, is I think medical providers don't sometimes do a good job with educating patients, right? I mean, we're just saying, take this medication, but then we're not explaining what our thought process is, and like why we think it's important to take it, and like what some of the side effects are, what people should do if they have side effects, right? We're just saying, here's your medication, good luck. So all good reasons. We are running a little bit out of time. I know there are like more hands up, but if you guys are okay, would you be able to answer question 2 and maybe also factor in some of the answers you had for question 1? I see Shireen first. Sorry.
Sure. Yeah, so just following up on continuing, like maybe he didn't like how the medication made him feel also, so that could be a reason. And then not following up with the medical or mental health provider. Maybe he didn't like how he was being treated, or he feels that he doesn't need treatment, kind of how we talked about earlier. Also cost possibly, or transportation. Maybe he feels like he didn't get a chance to choose the doctor that he wanted.
Yeah.
Yeah.
Yeah, absolutely. Karen.
So going with both of these, the one thing that we had discussed, and this is just a basic institutional way being an inpatient, I think works in our healthcare system. If you've ever been an inpatient, it's kind of a flurry at the end when you're discharged and you're given a piece of paper with like some names and some numbers. And we talked about maybe he didn't even know he was prescribed a medication. I work in healthcare, and when I've been an inpatient, it's difficult when you get discharged to know exactly what was said, because there's so many people coming in and out of your room. There's not that continuity of care from discharge to being back into the community to provide assistance to follow up. So it goes with both of those.
Absolutely. All good points. Muhammad.
Yeah, kind of similar. I thought if with the time that the short amount of time when she was discharged, I feel like it would have been very hard for him to come to grips with having for the diagnosis, or to understand the process behind what they were thinking. And as such, I could imagine he's not very accepting of the diagnosis, or whether like the mental health system is working with him or working more against him in that case.
Yeah, absolutely. Tiara.
I was also going to mention that sometimes mental health providers have many different patients, and he might not have been able to get an appointment that was available to him, or they might have rescheduled his appointment, or they weren't able to fit him in where he needed to be.
Yeah. Do we know that he has a working phone? I mean, what happens if someone cancels his appointment? Like, how does he know that he's not supposed to go, right? He can still go, but maybe he was also trying to call and he couldn't reach anyone. The other things I would say, it's in terms of costs, like we oftentimes talk about direct and indirect costs when it comes to like mental health. Like one, the cost of being involved in like having a mental health condition. But what also comes with having a mental health condition is, for example, in his case, not being able to hold a job, right? And then he might, once he's stabilized, he might be able to have a job, but on days where he actually has to go for an appointment, he might actually not be able to look for a job, or to apply for a job, to do interviews, or to actually go to his job, right? And these are all like costs, like which come, which we don't necessarily consider. Or he might not be able to go by himself because he doesn't drive, right? So who is taking off? Like, is it a family member? Is it a friend who can transport him? But then also, it's not only costs for this particular patient, but also costs for someone else in his, whoever helps him out. The other thing is like certain people mistrust the system. And I think, we see that some patients rather resort to like other kind of institutions to seek help, including religious institutions, or including, the thought process. I just had a patient today who said, well, I'm not here, I don't need a crazy doctor, right? When I introduce myself as a psychiatrist. So there's a certain perception about psychiatry, and there's a long past, and where this perception comes from. But like certain people also have a certain perception about psychiatry, and again, we're not fixing up the perception just because we took care of someone. Let's talk about question 3 for like 1 or 2 minutes before we move on with the case. Anyone taking on who wants to talk? Aslan.
I just wanted to also add on to something you just said there, and also answer question 3. Yeah. I think one of the big things also regarding question 2 is social stigma. Yeah. Particularly I actually did my senior thesis for my sociology major, looking at African-American college-age students and accessibility of mental health resources, and particularly amongst that particular population, there's a lot of research on social stigma in particular, and the fear of sort of reaching out, even if you know that you need help. So I think that's another social factor. And then in terms of question 3, I think this is sort of a tough question. I think for me, it would depend on, knowing if there's a potential danger, especially with carrying a knife around outside, and perhaps just having the neighbors sort of be aware of that potential danger. And I think for their safety's sake, I think that is important to have clear communication. But then also, I guess there's the issue of privacy, and then also stigma along with that. So I think it's a bit of a tough question, but I think some level of vigilance and communication is important.
Yeah, and then at the same time that you are aware of like the community's well-being, then the question also becomes: are you infringing on their patient privacy rights, right? What happens if the patient doesn't want you to talk about his mental health condition and how it relates to safety? The other thing which I just wanted to emphasize again is you cannot overestimate how much patients carry the social stigma around. Walking into a place which literally has a sign saying mental health professional or psychiatrist has so much stigma for certain people already that they, when they go into this place and some other people see them, there's already stigma attached to it. The other thing is, like, if they make a phone call or if you call them on the phone, some people share their phones, right? They're not using a private phone, but they actually share their phones amongst family members. And so if you cannot reach someone and someone calls back and is saying, hey, my name is like Stephanie, I'm calling from the Department of Mental Health, which we try to avoid it, but sometimes we can't or we don't. And so then the other person is like, so wait a minute, so why was someone like a psychiatrist looking for you? What's going on? Which comes with its own stigma. Do we have one or two more people who want to share their answers for question number 3? Mohammed.
Yeah, I think a lot of it comes, like I said previously, it's a very tough question, and it depends a lot on who the neighbor and how your relationship with the neighbors are. But also, it's important to know how to talk to the neighbors and how to talk about mental health in a way that doesn't create a stigma. I think that's like an important thing that the aunt or whoever is talking to in this situation would have to be conscious of as they have these discussions, which is like quite a challenging thing to do as well.
Yeah, and I would say, you don't necessarily need to make it about our patient, right? But you could offer just to go into the community and say, hey, I want to talk about mental health or like the brain, or neuroscience, and how it relates to stress and how to reduce stress. And this can be done, we don't know if this patient is religious, but oftentimes what I do is to go into religious communities and, just talk about the brain as such, right? Not even about mental health. And then while we talk about the brain, like issues pertaining to mental health, stigma come up. And there might be someone saying that's what I experience at least all the time. It's like, oh, we have someone in our communities who behave strangely. They're hearing things we can't hear. They're seeing things we can't see. They're screaming and we don't know what's going on. And then you as an advocate can actually intervene here, right? And say, okay, let's debrief. Let's talk about it, right? That's really good. So let's move to the last part. It's a little shorter. Who wants to read?
I'll go ahead and read. The psychiatric team in the ED decided that the patient does fulfill the North Carolina involuntary commitment criteria. The patient was referred to an inpatient psychiatry unit. He did lose access to his insurance since his last admission. The patient was stabilized on haloperidol. His symptoms improved to the point where he could work with the team on discharge and safety planning. During the last treatment team meeting with the patient before discharge, the patient asked, how can I pay for my medication? Do I have to stay in a homeless shelter now that my aunt does not accept me back? How can I find a job if people find out that I have schizophrenia?
Thank you. And these are real questions patients are going to ask you as an advocate, right? And we're gonna talk about briefly how to think about some of these questions. But I also just wanted to say when we think about structural competency, we need to think about domains like financial security, residence, risk environments, food access, and it goes back to the zip code lecture Dr. Bronner, zip code thoughts Dr. Bronner talked about, social networks, legal status, education, discrimination, right? I mean, we need to ask the patient, like, do you feel discriminated? Like, do by people around you. But also we constantly need to ask ourselves silently or loudly with other colleagues and people, like, do we discriminate based on like certain patient characteristics or condition, right? And then in terms of advocacy, well, the work starts today. You know, the largest impact again is to be made on the socioeconomic factor level, though, you know, oftentimes we are working up here on the counseling and education level. But then another way to think about advocacy work is like, you know, there's intrapersonally things you can do for advocacy, including, you know, what are your own belief systems? What are your attitudes? What is your knowledge, right? How do you take care of yourself? Being a mental health advocate comes with its own challenges. And then how do you take good care of your own mental health? Interpersonal, you know, how do we talk to neighbors? How do we talk to friends? How do we talk to family members? Institutions, remember, communities and policy and society, I just take this as a whole. Remember the first slide I showed you about like structural competency and structural racism, that this is actually be the reason that all these like institutions are the reason that there are social determinants of health, which then lead to health disparities. And so with these two like charts in mind, I stop sharing my screen and I give it back to the team. We have prepared a little blank Word document where we wanted to collect some of your thoughts about how you as an advocate could start working on these different levels, like intrapersonal with yourself, interpersonal, institutionally, community-based, and policy society-based. And remember, policy and society-based has the largest impact, but it's the most difficult to do. But just like, let's brainstorm some ideas and the team is gonna write it down and then they're gonna send it to you after the workshop. And we are gonna talk briefly about what to do with this sheet.
On the interpersonal, I would think just educate yourself.
Mm-hmm. And please just feel free to unmute yourself. Thank you for just doing it. No need to raise your hands. Also feel free, because we only have about 8 minutes left and we're going to probably spend like 5 on the advocacy part, but also feel free to write stuff in the chat while other people are talking. We will copy and paste.
Can someone read it out if it's written in the chat, please?
Yep.
Let's see the chat right now.
Another one for intrapersonal could be dismantling your own implicit biases and just being aware of like how those could come into play.
Absolutely. Implicit, explicit biases. Get involved with local mental health awareness outreach, Bruni. And including, I guess, NAMI and other institutions which will come and join you. Community, maybe get involved via volunteering. Absolutely. Intrapersonal, be kind to yourself, be kinder to yourself. How you treat yourself will impact how you treat others. So how to take good care of yourself, right? Okay, what else? We're gonna sort them after this lecture for you. What else? Intrapersonal community, listen actively and with empathy. Great one, love it. What else? Actively get to know your neighbors, right? And I would not, your neighbors and neighborhood and probably also communities, right? And like whatever your community is, it really depends, right? Some of it can be a religious community. Some of it can be a living community. Some of it can be a work community. So there are different communities we actually are part of in our lives. The other one was learn what resources are available to offer. Absolutely. Map out the ecosystem in your neighborhood, right? Know what's available already and know where the gaps are. If someone you know interpersonally has a distorted view on mental health, start a conversation with them about their beliefs and where they are coming from. I love this. These conversations can be tough. Be prepared and ready to resort to intrapersonal, where you need to take good care of yourself first, but also provide and challenge and support people, right? Absolutely important. Yvonne is saying, have a list of resources you can share. Absolutely. And these can be different resources. Can be patient-centered resources, can be family-centered educational resources, can be resources for your own well-being. Interpersonal, educate family and friends about mental health. Yep, perfect. Share mental health literacy with friends, have open conversations. I have heard about advocates who actually organize book clubs or movie events or these kind of things, right? Listen to music. There are a lot of songs about mental health conditions. Just talk with people about how they feel about it. How accurately or not mental health conditions are portrayed in certain social medias or in movies. Provide privacy to the patient. Important, right? Goes back to the point I made before. As much as we sometimes have the reflex to actually wanting to do the best for the patient, it might not be in the patient's best interest. So always make sure that you act on behalf of the patient, right? And not on behalf of yourself. Share your own mental health struggles to reduce stigma from those around you. Yeah, goes back to the vulnerability, right? Being vulnerable. But obviously you want to build an environment which is supportive and where you can be vulnerable at the first place, because you don't want to be vulnerable and then just be discriminated against. Be a good listener. Don't rush with giving advice. Yes, goes back to the point of empathy and active listening. Learn from people around you and vice versa. Very true. If what we don't know, other people might know. What else? We got keep an open mind and also understand that conversations can make people uncomfortable. Yes, even if they're comfortable with the topic, certainly. Lessen the use of the word crazy in a negative tone. Yep, I can't stress this enough with my patient today. It depends on like how today I resorted to humor and was saying, well, hopefully you don't see me as the crazy doctor here, but and the patient laughed and I laughed and but it's not addressing the issue. It's just like using humor as a mechanism here. Inform to clear up misinformation. Absolutely. Institutions, if there isn't already, try to create a group or community at your school, job, talk about mental health. Yes. Be aware of triggers you can avoid sexual trauma, be cognizant of terms like rape, etc. Very important. Educate the public. Mental health is similar to any other medical condition. There is a saying, no health without mental health, right? And we get organizing events in the community, self-awareness. I love all of these. Other things to consider, especially on the policy level, is know who your senator is or who your representative is in the House, and send an email or sign up for like NAMI's emails list. Or there are other advocacy groups which you can follow and subscribe to, and they will email you if they need your support in terms of like passing legislation. We don't expect you to pass legislation by yourself, but you can advocate for legislation to be passed, which makes the world a little more diverse and equitable and just and inclusive, including people with mental health conditions. Work towards social change, incorporate more mental health understanding into youth education. Yeah, in schools, outside of school, in neighborhood talks. So there are many, many different ways. Well, we have such a rich content here. As I said before, we are gonna sort it for you and maybe complement it with a few resources, which you also, I guess, will come up over the next couple of weeks. But the one thing I would encourage you, this is like an 8-week-long class and course, and I would encourage you in a sense of like an 8-week challenge, that you actually for each of the coming weeks, you pick one of these challenges or like one of the advocacy things you just discussed and actually start implementing it. Like think how you would think about it and implement it. If your goal is to talk with a friend about mental health, then talk with one friend in the next 7 days until the next session and actually just do it and see what happens. And if it doesn't go well, do it again in the following week. And I think, I leave it to the Bruni and the team to see, how it can be incorporated in the next couple of sessions. But, I think we all want to learn from you and see what you have done so that we can be inspired and also do similar things in our communities. So, we will reflect on this like 8-week challenge, and Bruni and the team will send out more guidance and the instructions. But I stopped talking here. We are like 30 seconds before 9 p.m. and we didn't even leave time for questions, but I'm happy to stay behind for a few more minutes. Back to you, Bruni.
Yeah, thank you for everyone for staying this whole time. You guys will be receiving an email with your post assignment that will be due by the next time we have our class, as well as a workshop feedback survey. Also, thank you for everyone who donated to LMHA. I know it's people like you that keep this organization going. Everyone here is donating their time. And so with us also applying for grants and stuff, we're going to use this money to make this program better, particularly the volunteer portion, because we need things like liability insurance and contracts with different organizations. There will also be another link for people who didn't get a chance to donate, where you can donate at any point in time. So thank you guys so much. Please feel free to ask questions if you have them. But other than that, see you next time.
Thank you.
Goodbye.
Thank you.
Thank you.
Oh, Diana? Go ahead and mute.
Oh, sorry. This is just a quick question. I know we've talked a lot about how it's kind of almost inherent discrimination in the medical field against people of color or Hispanic or Black Americans, but just in your own personal experience and throughout your own educational background, how are you taught to handle those things?
Yeah, I think Dr. Bronner and I might have very different answers because I trained in Germany, and the short answer is I was not trained in it at all. I think there are a lot of issues pertaining to DEIJ in Germany, but we are not really taught about it. So it was only when I came to the United States that I learned picking up some of the discussions, and I also saw it in my daily work. And to learn more about it, I joined the DEIJ strategic group here at Duke, and proactively go to lectures, talk to people, talk to patients and their family members, work with communities, right? Because I strongly believe that everything we know has to come from communities. No one in a office can tell me what the reality is on the ground, but really I want to talk to communities. So short answer is I really try to hear from the people I'm trying to work with.
Thank you.
Dr. Bronner.
Yeah, I think from my point of view, I think it unfortunately is the same, despite the fact that we've had to deal with so much racism in this country. When I was coming through, nobody ever talked about it. I think nowadays, people are talking about it more. It's being more incorporated into day-to-day work in the hospitals nowadays. But yeah, unfortunately, people have had to seek these things out on their own. And unfortunately, because all of us have grown up in a racist society, those things have impacted patients. And so,
I think you're muted.
Sorry. And so I'm glad that this issue is more prominent nowadays, but unfortunately it takes these societal incidences or events to happen to push people to talk about this more.
Ngozi.
Hello, everyone. My name is Ngozi. I just want to say shout out to the LMHA team. I really appreciate the first workshop, and I'm excited for the rest. I had a question specifically for you, Dr. Bronner. You mentioned the CDC health pyramid and how the socioeconomic factors. I was wondering, as a physician in your day-to-day practices or clinical interventions, how do you incorporate or how do you focus on socioeconomic factors with your patients, or do you at all address them?
Well, for me in psychiatry, more than in the medical side, that's what we do on a daily basis. We work very closely with social workers because we know, and at least we know that social factors are very, very important, and it impacts whether the patient is going to do well or whether they're going to be rehospitalized. So as soon as a patient comes onto the unit, I'm asking the question, You know, do they have a job? Do they have any money? Where are they going to go? All of these things are from day one. That might have impacted how they even got to me, but it's also going to impact whether they're going to come back in the next week. So this is at least 50% or more of what we do as clinicians.
More so in psychiatry than anywhere else, would you say?
I think it is. I mean, when I do consult work and work on the other units with psych patients, they don't do as much, and they sort of push a lot of this onto the patient. So where I might discharge somebody and say, I'm going to call and make sure you have the appointment, I'm going to talk to your family. On the medical floor, I've noticed that sometimes they'll go to the patient, well, when you get home, go ahead and call and schedule the appointment. Who's going to be more likely to go to the appointment? This person that already has the appointment, or the person that has to call for the appointment? Right. So, but I mean, it's a lot of work, and, you know, and so I can see why, you know, you don't have a lot of time to do all of this stuff.
So how do you balance that then?
Well, I mean, for me, I know how important it is. And so I just have to spend the time. If I don't want these people to come back, then I have to do this extra work. Unfortunately, there's not a whole lot of places to send people. You know, a lot of people are homeless. A lot of people don't have money. A lot of people don't have jobs. And these are the things that we really can't impact a lot of times. And so it can be frustrating from my point of view when we've done all we could to send somebody out and they still come back.
And just a real quick follow-up question. I apologize, my last question, Dr. Bronner. Would you say, in regards to the specialty of psychiatry, would you say that there are a shortage of psychiatrists? I know there's like a shortage of primary care physicians, but would that idea still be for the field of psychiatry as well?
Yeah, definitely. I mean, I think a lot more people have gotten into it over the years, but yes, we still have a shortage. So if anybody's interested, come join us.
Great question, Goldie. Yeah, certainly a sort of diverse workforce in psych.
Yes, yeah. Definitely.
Mm-hmm. And you know, the stigma behind psychiatry is part of the reason. I think you're muted, Leslie. Oh, you're muted.
Yeah, stigma, money, and all kinds of things keep people away from psychiatry.
Oh, I also know you have a doctorate in public health. And how do you feel that has sort of informed your role as a psychiatrist and physician?
Well, I think for me, I focus more on probably social determinants, maybe more than even other people in psychiatry, just because that's a part of my background. And so I knew how important that was even before I got into psychiatry. And so I think that has been helpful for me in that respect.
Any other questions? Well, if there's nothing else.
There was one in the chat. Grace is wondering if ADHD is considered a mental health illness or a learning disability. And I'm not sure if there will be a lecture about ADHD, but I think what I would say is it's not a learning disability because it doesn't necessarily affect a person's ability to learn specific things. You know, they can still learn how to speak a language, they can still learn how to do math, they can still learn like how to read and write. But what is what the mental health condition is affecting is how they learn. And you know, there are challenges in learning because, you know, they might not be able to focus or to be attentive. And so it might just take different strategies in terms of like how you educate and teach someone with ADHD.
Yeah, I also read this thing that talked about how ADHD is not necessarily the lack of focus, but is the hyper focus, being hyper focused on things that you like. so much so that you're missing things. And so things that you don't like, it's harder for you to pay attention to it, which is why increasing dopamine helps people pay more attention and helps decrease ADHD symptoms. Oh, so many great questions. All right, well, you all are free to go if there are no other questions.